Mm-hmm. Good evening, everyone. Can people hear me?
Yes.
You can hear me?
Still can hear you.
Okay, we're about 15 minutes early, and so please be patient, and I'll set this up so we'll be able to start hopefully on time. So I appreciate everyone coming in.
Thank you.
Hi there.
Hi, I just unmuted Michael and myself, John Mahalski, who will be co-hosting this. And right now is that the doctor should be calling in a short period of time. We expect him at 7 o'clock our time. So talked to him earlier today. So everything is on schedule. He's able to call in, and there should be no problems whatsoever. So
Awesome.
So for everyone, I will say it premature to say thank you to all. And hopefully today will be a good presentation. And we'll be starting in about 10 minutes. So I'm going to mute all, including myself and Mike. And like I said, we'll come back on a few minutes before 7 o'clock. So thank you very much, all.
April 26th, you can win $7,000 a week for life. JTR Roofing. They have you covered from the roof on down. JTR Roofing.
Hi, Laura. Hi, John.
Hello there, doctor. How you doing?
I'm good. Can you hear me?
We can hear you fine, perfectly.
Oh, that's kind of nice. We can work with that.
So I just noticed that I saw you log on. So that was just going to unblock you from your voice. So from that standpoint.
You're the boss.
No, I'm just one to try to help out. When as I said, we try to make it as easy as possible for the people who are presenting, and we have found out that doing it this way seems to be the easiest, because we have run into problems with, how can you say, software incompatibility with browsers and web and different operating systems. So allowing us to, how can you say, execute the controls makes it easier for the people, and that way there's no frustration on the presenter standpoint. So
yeah. So just so you know, I do have phone service. I've got the call-in also kind of queued up just in case there's any kind of a problem.
okay, and like I said, right now, I received your updated slides. I appreciate it. Thank you very much. I've incorporated it into the presentation, and I do have your other two documents that you sent to us, queued up also.
Yeah, and those are just maybe more things that you could put on the website that people could download if they want to use them. Because I refer to them as images in the presentation.
Okay, fine, great. Excuse me.
I've also had a couple inquiries in the support groups online that were tied up or for some reason could not participate tonight. So they're very happy to know that this is being recorded, and we'll have it on the Michigan chapter's website here forthcoming, so that those that couldn't can. So
yeah, that's great. Things like this are there's something that people want to look at when they want to look at it. And I think the web's a really good way to disseminate them personally.
Mm-hmm. Well, Dr. Martin, I'm Michael Bessert. I'm a patient advocate. I'm from St. Louis, Michigan, diagnosed in 2013 with systemic scleroderma diffuse. And being kind of in the sticks, this is my way of contributing and advocating for this disease. Plus, I learn. It's great. So it's a twofold blessing for me. I learn and I can advocate. So,
yeah, well, these are rare diseases, and it's hard for people to connect with each other. When I was in high school, I lived in Saginaw, so I know exactly where St. Louis, Michigan is. Yeah, of course I do. My brother-in-law used to live in Hemlock, Michigan.
Oh, yeah.
Which is not desperately far from there. And so I'm very familiar with mid-Michigan. And years ago, a number of times I went up to, used to have this wonderful lady in Mount Pleasant who had these huge scleroderma support meetings.
Really?
And yeah, there'd be 150 people would attend. She was amazing.
Wow.
Yeah. But it just, the world changes. And
yep, it does. Because there's the nearest support group is Grand Rapids or Livonia, I think. So yeah, I'm a distance from them.
Yeah, so this is good.
Yep.
So the way I structured this is that there's a first part which I really actually like a lot, and I think it's going. I hope it's going to be something that's of help, and then it's more kind of based on treatment, and then I had structured it that there would be like a question and answer, and then maybe a break, or I'm not sure. And then we would go on to talk about goal setting, which I think is another really important basic thing related to coping with any chronic disease. Can you just tell me how you guys usually handle questions in the past?
Normally is that because of we get such a large group, what we try to do is that, and we're near the start time anyway, so I'll just speak to the group and I'll say good evening all. Appreciate everyone attending. To address Dr. Martin's question is that on questions, I'd like you to basically pose them to me, and then I don't want to say proof them, but I will read them to the doctor. And what I try to do normally, and it's worked in the past, is a lot of times we can combine one or two questions together and we can get the answers for multiple people. Plus, it does help because, human nature, and I'm one of those particular, is that a lot of times we want to do a follow-up question to the question that we just asked, but to be fair to everyone else, we try to get as many questions as we can as possible through, and that's the reason why I don't want to say we try to vet them, but we try to basically funnel them through a single source, and that source is me. So if you have questions to anybody, to the doctor as a presentation, please bring them up and I will read them, and I will address them from the person that we receive them from. So from that standpoint, in other words, I might not say your name, but I basically will say, well, from where you're from, as being from New York or from Pennsylvania, something like that. So,
yeah.
So
I think that's great. Good.
So, well, we are on 7 o'clock or 6:59. So we're going to say we're going to start on time. So I want to introduce myself, and I want to introduce our panel right now. And that panel is myself as John Mahalski, part of the Michigan Board of Scleroderma Michigan chapter, and myself and Michael Bassett. And Michael, why don't you speak and tell us a little bit about yourself?
All right, my name is Michael Bessert, going on 62 and diagnosed at the age of 55 in 2013 with systemic scleroderma diffuse. Live kind of in the proverbial sticks, so this is my way of advocating the disease, learning, and getting involved. And I do have the intro and the bio to read whenever I'm ready to do that. So,
Michael, why don't you do that for us right now? Why don't you read the bio for our speaker, who I will say thank you at this point, and I will once again appreciate his efforts to share with the scleroderma community, Dr. Martin. So Michael has a little bit of to talk about Dr. Martin and his accomplishments and his help that he's given out to the community.
All right, first up, I want to welcome everyone to the Scleroderma Foundation Michigan Chapter's web-based 29 educational series. This webinar is being offered as part of our strategic planning efforts to move towards web-based learning experiences for the next 4 years in an effort to reach more patients, caregivers, and family members who are seeking to obtain accurate information about scleroderma. There are individuals from all over the world participating in this webinar, emphasizing that we can be connected and sit in front of our computers while staying in our homes and offices. This is the second webinar in a series and focused on innovative therapies for scleroderma patients. There will be 4 more webinars presented in 2019, and you can locate information about them on the Michigan Chapter's website. If you'd like more information about these, you can find the information on the National Weekly E-Blast or on the Michigan Chapter's website, which is scleroderma.org/Michigan, and Michigan is spelled out. This evening we have with us presenter Dr. Richard Martin. Dr. Martin is a native of New Jersey, earning his Bachelor of Science degree at the University of Michigan and MD at the Michigan State College of Human Medicine. He completed an internship at Butterworth Hospital, Grand Rapids, Michigan, his residency in primary care internal medicine at the University of Rochester, New York, and a fellowship in rheumatology at Mayo Clinic, Rochester, Minnesota. Subsequently, at Michigan State University, he earned a MA in Education Psychology and Instructional Design and completed a 3-year clinical epidemiology postdoctoral fellowship. I read that again wrong. Dr. Martin founded the West Michigan Rheumatology in 1991, and his practice continues to be an excellent resource for the scleroderma community in Michigan. Dr. Martin's research has focused on evaluating emerging therapies for rheumatoid arthritis, Raynaud's, and scleroderma, as well as developing decision aids for patients considering biologics. Dr. Richard Martin is a member of the Scleroderma Foundation Medical Advisory Board and serves as an advocate for scleroderma patients around the United States. The Michigan chapter welcomes and thanks him for his willingness to present today. Dr. Martin, I turn the floor over to you.
Great. Well, thank you so much for your introduction and your kind words. So today we're going to talk about this will have 2 parts. One relates to treatment algorithms for scleroderma according to experts, which is more related to what are good treatments that are now considered standards of care. And then the second part is I want to talk about the most basic of self-management techniques, which is goal setting. So they're very different, but in some ways related problems. And I hope this is helpful to you. Could we go to the second? Oh, thank you very much. Yeah, so treatment algorithms are recommended steps for good care. They can vary from country to country, but they represent the opinions of experts of general pathways for care for typical patients. They are guidelines. They don't work in every situation, but they're helpful as they offer a consensus of experts as a starting point. So if they're used properly, they can inform patients, physicians, and insurers, or national health plans, and lead most people to good care more efficiently. So on the left side is a treatment algorithm at a public hospital in La Paz, Bolivia, where one of my patients was admitted. And this is what she had to do to get antibiotics. Her husband had to go to the cashier and pay for the medicine and then take the receipt somewhere and pick up the medicine. And it's pretty scary and pretty convoluted and hard to understand, right? And that's something that is often the case in scleroderma. People see patients that maybe aren't that experienced with it, maybe scared of the disease. And people follow this second diagram on the right, which we don't want to follow, which is kind of being in a rat maze. These pathways are tools, and they can help us to go straight towards the most efficient treatments. So could we have next slide? Could we have next slide, please? Can you hear me?
We are on the next slide. I'm sorry, Doctor.
Oh, one more. Yeah, there we go. Thanks. Thank you very much. So Jack Wenberg was an internist at Dartmouth University who became interested in studying variation in the provision of healthcare in the mid-90s. And he's a very interesting man. He studied the rate of surgical procedures per population in Maine. And he found that there were unexpected variations in surgical rates. And he just couldn't explain this. In some surgical areas, there were lots of tonsillectomies done and per population, and others not so many. This led to a really major undertaking called the Dartmouth Atlas. Next slide, please. Next slide.
Yep.
There we go. Thanks. And so they, based on the series of investigations and policy formulations, he suggested three main reasons why there are unwarranted variations in healthcare. And the first is the underuse of effective care. And what that means is medical care which is not meeting national standards. So this is why I wanted to go through these algorithms today. I wanted to unpack and explain to you what a pretty large group of international rheumatologists has said, this is what good care looks like. It's something that you can use to compare your own personal pathway with. It may not be exactly what you need. It's not appropriate for every person, but this is one way to basically to address that. The second is overuse of supply-sensitive care. So that's using interventions because they're available rather than they're most appropriate. So let's say you're a hospital administrator and you spent $6 million setting up a lung transplant program. And you know that your budget requires you to do 30 lung transplants in a year. Sometimes the interventions are offered not only because they're the best things for the patient, sometimes because they're trying to meet the goals of the institutions. So that can be a problem with diagnostic imaging like MRI scanning, which can be overused, invasive cardiac testing, lots of things. So, and then the third is the misuse of preference-sensitive care. And that's a situation where there are two or more medically reasonable options. And the treatment choice shouldn't really be the doctor's, it should be the patient's. And it should be based on their values or what's most important to them. So the most classic example of that is a woman with breast cancer. And it's pretty much agreed upon that lumpectomy and radiation versus radical mastectomy have similar outcomes. So the decision to have one approach or the other really is not up to the doctor. It's really something that the patient should decide with the doctor based on what they feel is most important. Can we go to the next slide?
Come on, John.
Thank you. So this leads to a term called shared decision making, and it's a tool that we can use to increase decisions. And it's a collaborative process in which patients and clinicians make treatment decisions together. They integrate evidence and patient preference and values. What's a good decision? It's informed. The doctor shares their expertise and information with the patient. But going back in the other direction, the patient shares their values and preferences with the physician. And then together they try to come to a decision which is consistent with what's important to the patient. And then the final aspect of it is that it's acted on. Not that just we think about making a decision, but that we make a decision and use that to move forward in our care. Now, sometimes that involves not taking on any new treatment. So declining treatment is also a choice. Next slide. So this comes back then, so how do we reduce unwarranted care? Well, we disclose these national standards of care to people, like treatment guidelines, like I'm going to do today. We share decision-making to increase preference-sensitive care. We engage everybody who's involved in the care team to support your decision-making and acting. And so, of course, all people within the healthcare team need to know what's going on. And then one thing that we've done a lot of, as well as other national centers, but we're probably more advanced than many in the US, honestly, is we've developed decision aids in high-stakes medical decisions. And we have adopted them at the site of care. So this is actually the policy paper that I've cited here that guided the development of the Obama health plan. And you might agree or disagree with the health plan in a general way, but I think these four principles are very helpful to everybody, and I'm grateful for that. So let's go on now to the next slide. And this describes a paper that's just published in November, and it was by Dr. Fernandez Cordina, and the lead author is Janet Pope, a very well-known and really useful investigator at the University of Western Ontario in London, Ontario. So they're our close neighbors. And they surveyed 62 scleroderma experts to find the consensus on what are best practices. And they looked at 7 different disease problems that happen in scleroderma and tried to basically create algorithms or steps or pathways of care for each of those. So I'm going to try to work through each of these. Let's go on to the next slide there. And I'm just going to try to unpack each of these slides and let's see what kind of thoughts you guys develop from that. So here's the first, well, Raynaud's phenomenon. Raynaud's phenomenon is something that's experienced by more than 95% of people with scleroderma. It's that tricolor changes and sensitivity that occur with exposure to cold. They divide this into mild Raynaud's. You can see that on the left side of the tree. People have overall less than 1 attack a day. And on the right side of the tree, more severe Raynaud's, and that's 3 or more attacks a day about. Now you can see that there are some initials in each of these little boxes, and I've given you a key on the right side of each slide that translates what those are. So I'll walk through the exact slide, but if you're looking at this again, maybe online, or you're backing up, you can double check. And so this would be interesting to kind of think about, well, what am I doing for my Raynaud's phenomena, and where do I fit into this? Or why don't I fit into this? So the first for mild Raynaud's is first-line therapy is a calcium channel blocker, CCB. And you can see in the key on the right side examples that are nifedipine or amlodipine. And about 72% of the doctors use that as their first line. And then, oh, I'm sorry, that was, yeah, no. And then 90%. And if people did not have sufficient control of symptoms, then they would typically add a phosphodiesterase inhibitor. And you can see on the right side in the key, that would be drugs like sildenafil, that's Viagra, or tadalafil, which is Cialis. And if people did not have sufficient control of the Raynaud's with both of those together, then about half the doctors thought that they would add a third drug, an angiotensin receptor blocker like losartan or valsartan, another blood pressure medicine, or move to a second calcium channel blocker.
Doctor, I'm going to ask you and stop you for a moment. I will ask you is that when you show from the first line to the second line, you say the channel blockers address 90% of the issues. Now the second line said addresses 72% of the issues. Is addressing 72% of the remaining 10% that aren't addressed, or is it addressing 72% of the overall 100?
Yeah, so this process, good question, thank you. This process was talking with doctors saying, if someone was given a calcium channel blocker and they did not respond to that sufficiently, what would you do next? And 72% of the experts said, I would add a drug like sildenafil.
Okay, thank you. I think that clears it up then.
Okay, good. So none of these are hard and fast. There isn't 100% response that every expert would do the same, would do the same thing, but it shows you most in these cases would move in this direction. So with more severe Raynaud's, again, people would start with a calcium channel blocker like nifedipine or amlodipine, and they might 93% said that if they didn't improve with that they would move on to sildenafil or to tadalafil, a phosphodiesterase inhibitor, or a prostanoid. Now, I've got a comment that some of those people who responded to this this consensus building exercise were not in the United States. And there are no prostanoids which are available orally in the United States right now. We did a clinical trial of oral iloprost a number of years ago, and it didn't work. There's another drug which is working its way through clinical trials, but that is not actually currently available. So in this case, in the second line, if people don't respond to sildenafil or tadalafil, the phosphodiesterase inhibitors, 85% said they would would then for sure go on to that or a second drug. And then on the fourth line, again, changing to another calcium channel blocker. And if people did not respond to these oral agents, then as a sort of a fifth stage, they talked about using Botox injections around the nerves in the palm, or surgery around the nerves in the palm to try to cut the sympathetic nerves, which cause the blood vessels to constrict. So lots of other treatments are also used as an adjunct in Raynaud's phenomena. And you can see in the box in the bottom that they talk about other things like blood thinners like aspirin or pentoxifylline, or cholesterol-lowering medicines like statins. Fluoxetine is an antidepressant. Another name for that is Prozac. And there's actually clinical trials show that improves Raynaud's. Topical nitrates might also be used, but sadly, the best formulation of that actually is not available in the United States. So we're going to follow sort of the same pattern, and we're going to keep going now through the next disease group. John, is this okay, or do you want to pause at some point here?
No, you're doing excellent, doctor. I mean, right now, is like I said, I think going through this, I think it's excellent. It allows our patients to understand is that some of the treatment processes that their doctors do choose and why they choose them, and it's not from the standpoint of how can you say it, a hit or miss, but it is backed up by clinical trials, and they are relying upon some of the information that you're presenting here.
Oh yeah, and that's really true. And the people who participate in this all were people in the Scleroderma Clinical Trials Consortium. So these were experienced, scleroderma centers. People have seen a lot of folks with scleroderma, and it had taken part in probably a lot of these trials. I mean, I've taken part in most of the large-scale clinical trials over the last 25 years in Raynaud's and in scleroderma. So, there's a lot of people who have experience and good insights. So here on this third one is scleroderma-related skin ulcers, which is a very difficult problem. You can see there's two arms to this tree. One is prevention, and one is active treatment. So one is the September approach. Before the Michigan cold winter starts, what do we do to try to prevent someone from getting Raynaud's ulcers this year? And then the right side is once someone develops a Raynaud's ulcer, what are the best options available? So on the left side, again, calcium channel blockers. If there's not sufficient, phosphodiesterase inhibitors like sildenafil and tadalafil. Then there's a third drug, bosantin, which is actually an endothelin receptor antagonist. And we actually did a couple of those trials, and it's interesting, bosantin does not heal established ulcers. We did not demonstrate that. Actually, Dr. Seibel was the primary investigator, but that did not heal ulcers, but it did prevent the development of ulcers. So that is often used. It's a drug also used for pulmonary hypertension. The third line is prostanoids. Again, the problem is in the United States, there are no oral prostanoids. And then, then for prevention. And then the fifth is digital surgical sympathectomies. So people who have active ulcers, what do you do to try to improve that? You use medicines that dilate the blood vessels to make them bigger, like calcium channel blockers, or phosphodiesterase inhibitors, like sildenafil or tadalafil. And then if people have ulcers which are really troublesome, or the digit is threatening to be lost, and some people, sadly, with scleroderma do lose fingertips, a third line is using prostanoids. And so that's an example where you actually admit somebody to the hospital and you put an IV in or a central line in, and you give them 3 days or 5 days of a IV blood vessel dilator. So epiprostanol is also called Flolan. That's gone through a central line in your neck, actually. Iloprost is something that's given through the IV. Alprostadil is another one. But that's what that last third line is for the active treatment of ulcers. Also, might use anticoagulation in those cases, like aspirin or heparin and Coumadin or Lovenox. There are a number of other kind of adjunctive things done too. So let's go on to the next slide. So this is something that maybe you'd be less involved in decision-making, to be truthful. And this is in this very unfortunate group of people who get accelerated hypertension. It's a life-threatening, terrible situation. It's where people get very severe hypertension, 180 over 110 or 120. Sometimes people get congestive heart failure with this because the heart is working so hard against the pressure. It is a medical emergency. And the really important treatment are the angiotensin converting enzyme drugs. And you can see on the key on the right side, that would include captopril and enalapril. And these are really transformational drugs. Before we had these, it was very difficult to treat these people, and they were much better than any treatments that we had before. If doctors found that it's not sufficient, they would often add calcium channel blocker. That is not sufficient. They might add a third drug on line, like losartan or valsartan, and then even a fourth line of antihypertensive drugs. These are typically, like I said, if it's really that bad, people are often in the hospital. Let's move on to the next. So now we come to pulmonary arterial hypertension. So the first thing I want to say about this is that pulmonary arterial hypertension in scleroderma is a unique problem. There are other people who get pulmonary hypertension. They call pulmonary arterial hypertension group 1 pulmonary arterial hypertension. So it's a specific kind that you see in scleroderma. That's a little different than people who have other causes, group 2 to group 5. And those might be people with congestive heart failure related to heart disease or emphysema or some other kind of lung disease, or people with recurrent clotting like pulmonary embolisms. So those would be different. So we're really not talking about those people, but this talks about the people who have unique involvement with the pulmonary arteries related to scleroderma. And you can see on the left side, it talks about people with mild disease, and they describe the New York Heart Association class. And class 1 and class 2 are people who have no limitation with ordinary activity or slight limitation by shortness of breath with moderate exertion. So not really much limitation. The people with more severe disease are the people with symptoms with minimal exertion. So that's a very important sort of hinge in terms of decision making. The treatment on the left side of mild pulmonary arterial hypertension usually starts with these phosphodiesterase inhibitors like sildenafil or tadalafil. And I would point out that interestingly, sildenafil is now about $25 a month, because it went generic, and it was about $900 a month last year, which is sad and happy at the same time. If a person has mild pulmonary hypertension and they don't improve sufficiently in terms of the pressures that are measured on an echocardiogram and symptoms with the phosphodiesterase inhibitor, then 85% of the specialists would add an endothelin receptor antagonist. And that would be, you can see in the key, bosantin, acetylcysteine, or others. And if people do not respond to that, then they would consider adding a prostanoid. And usually those are either inhaled treprostinil, IV epiprostinil, or inhaled iloprost. People with more severe disease, they use very similar tools, but they move more quickly to the prostanoids and the endothelin-1 inhibitors. And you can see at the end, the fourth line, which is lung and heart transplantation, which I would say is an experimental procedure that's really not been validated in scleroderma, but there are some centers that do lung and heart transplantation in that case. Interesting story is that Richard DeVos received the heart of a young woman from England who had pulmonary arterial hypertension, and she was going to die, and they were going to throw her heart away. And Richard DeVos got her heart. And even though he had his reason for having heart, and her heart was perfectly adapted for his needs. And he got another 15 or 18 years from that, which is pretty amazing, really.
I guess for many of the people, like I said, Doctor, who don't know, Richard DeVos was influence in the Michigan Grand Rapids area, and his wife is now serving as Secretary of Department of Education. So that is who is speaking about. So
Yeah. Betsy's actually, I think, his daughter-in-law.
daughter-in-law. Okay.
Yeah, but they're very prominent philanthropists in West Michigan. Done a lot of good for a lot of people. But anyway, he received a heart transplant, and that's an interesting related story. Can we move on to the next slide?
Here we are.
Thanks. So now we get to scleroderma. So we all identify scleroderma by the very prominent and troubling skin changes, the thickening, the tightening of the skin, the difficulty moving of your fingers or limbs because of tightness, sometimes tightness of breathing because your chest, the skin is thick. And in this study, what they did is they tried to differentiate 3 different types of people with scleroderma. The MRSA means Modified Rodman Skin Score. And that's just a way that we evaluate skin thickening in different parts of the body. But I think you can reread those to say mild, moderate, and skin disease for the 3 arms of this flowchart. So people with very mild disease on the left side, most of the experts suggested using methotrexate as a first-line treatment. Methotrexate's been evaluated in a couple large-scale clinical trials and shown to have some or marginal benefit for the skin. And that's, I think, why you notice that, but it's very widely used and it's very safe and it's not expensive. But I think that's why you also see that 89% of the experts felt that if people did not respond to methotrexate, that they would move on to mycophenolate. MMF is mycophenolate mofetil, which is an organ transplantation drug, which has really turned out to be a pretty dominant drug in the treatment of scleroderma these days. Another happy story about that was $800 a month last year. It was very difficult to get for people with scleroderma who have Medicare because it's not an FDA-approved treatment for scleroderma. And now that's closer to about $30 a month now. It's a generic drug. So if you move on to people with moderate disease, there is less consensus about using methotrexate early on. And 61% of people suggested moving to mycophenolate. Of people who failed mycophenolate, though, the majority suggested being much more aggressive and adding a chemotherapy drug, cyclophosphamide, IV. And that's typically done once a month IV for 6 months and then sort of tapered over the next year or two. In people with the most severe, rapidly progressing and aggressive, extensive scleroderma on the right side, there was a general consensus that they should not use methotrexate, that mycophenolate is the best drug to use. If people did not respond appropriately to mycophenolate, interestingly, the experts did suggest trying methotrexate. And then again, many, if they fail that, moving on to cyclophosphamide. And then you get to the 4th line, which is kind of an interesting development, which is the addition of autologous stem cell transplant as an option in scleroderma. And there are a European and American study which have shown that to improve survival, although it is still a very invasive treatment that has a significant chance of death from having the procedure itself. And then the 5th side, the 5th line is they're talking about referring to for a clinical trial. And I think that just recognizes that we really don't have an effective treatment for aggressive skin disease in scleroderma and for the underlying scleroderma disease process. And I spent most of my career taking part in clinical trials, trying to help in that process of, one drug at a time, trying to figure out what works and what doesn't work. And through that process, we have learned an amazing amount in 20 years. We're much better at measuring scleroderma. We're much better at knowing aspects about how well people's lives go. And so, clinical trials are helpful. They're not for everyone, but there's a place for them. And that's why I think that's for the most severe people, particularly in the first, 2 to 4 or 5 years of the disease, where it can make the biggest difference. So let's move on to the next slide. So interstitial lung disease, that's kind of a technical term. So frequently people with scleroderma will develop scarring of the walls of the lung. That's different than asthma, where the tubes that go from the mouth down to the heart, or down to the lungs, spasm, or different from emphysema, where the little pockets at the end of those tubes get broken down. It's a problem of gases, oxygen, moving from the lung pockets into the blood. And so that membrane can get scarred and thickened and makes it harder for gas to diffuse in and for carbon dioxide to diffuse out of the lung. It's been pretty exciting area though, and I would say 10 years ago we had no effective treatment that we were aware of, but there's been a lot of progress. So this particular diagram shows induction and maintenance. On the induction means initial treatment, and then after the initial course of treatment, say for a year, then maintenance. So the first line is mycophenolate, and there are a number of studies showing that can certainly stabilize and perhaps improve people's pulmonary function. If people have progressive disease despite mycophenolate, MMF, then the majority of the experts felt adding IV cyclophosphamide was appropriate. That is a little bit of a riskier medicine. It does have some chance of secondary cancers with it. It has bleeding from the bladder. It's got its own other set of problems, but it can be safely used. A third line is a drug commonly used in lymphoma and in rheumatoid arthritis, Rituxan, and that's given as an IV, 2 infusions given, and then no treatment for 6 months. And then again, they go on to lung transplantation or autologous stem cell transplant, or referral of a clinical trial for very aggressive diseases. If you have an initial period of treatment following this induction pathway, then how do you maintain that over maybe a series of years? And mycophenolate is a very well-tolerated drug, and that was the dominant drug to be suggested. Another drug maybe everybody hasn't heard about is called azathioprine, which is another very old organ transplantation drug. But it's very commonly used in lupus kidney disease. It is approved for rheumatoid arthritis. So can we go to the next slide?
Just 1 second, Doctor, before you leave, I just want to ask a question. I mean,
Sure.
On this particular area, as you talked about the interchangeability or the diffusion of the carbon dioxide, have we been able to learn anything because of the amount of research and investigation that has been through smokers and the effect of the cigarettes on the lungs? Has we been able to gain additional information, or has that been helpful for us to address some of the things that our patients experience?
Well, that's actually a really important question. I mean, I think we all know that smoking tobacco, or I suppose a lot of marijuana, can have an effect on your lungs. Maybe heating your house with an unvented wood stove could do the same thing. But that, and so you would want to try to minimize those things, because there is an element of thickening of the interstitium in the lung. So there is some interstitial lung disease that can happen with smoke inhalation, although it's more of an emphysema-like process that occurs. But if there's anything that you can do to diminish the damage on an ongoing basis, like smoking, that would be a great thing to do, is to try to quit smoking. Mm-hmm. Also, it's a big factor in terms of Raynaud's and digital ulcers. And I would say many of the people I take care of who have had 1 or more finger amputations with scleroderma either had been long-term smokers or even continue to smoke.
Okay, thank you, Doctor. I'll move to the next slide now.
Thanks. All right, and so I think this is the last one on these algorithms. So it's interesting, people with scleroderma can have inflammation of the joints. And for some people, particularly early on in the disease, that's kind of a big problem. Maybe you don't have lung disease, maybe you don't have really fast, rapidly progressing skin disease, but stiffness of the hands and swelling can really be functionally a big problem for people. So in this case, the first line suggestion was to use methotrexate. I think I mentioned that methotrexate is an FDA-approved treatment for rheumatoid arthritis. It's really the most prominent treatment for that. And the arthritis that can be seen, or tendon inflammation that can be seen in scleroderma, does often respond to that. If people do not respond to that sufficiently, then adding low doses of glucocorticoids like prednisone was suggested by almost half of the investigators. The challenge on that is most would suggest using less than 10 milligrams a day. Using more than 10 milligrams of prednisone a day does increase the risk of getting that high blood pressure problem we talked about earlier, scleroderma renal crisis. If people did not have a response to methotrexate and low-dose steroids, then the majority suggested adding a second drug like methotrexate called hydroxychloroquine. And that's a very common drug used in lupus, for lupus skin disease, but also for arthritis. It's an FDA-approved treatment for rheumatoid arthritis. And if those did not work, in the fourth line, there's rituximab, which is a monoclonal antibody that reduces the blood cells that make antibodies. And we talked about that earlier, sometimes used in interstitial lung disease. The thing to the right of that is tocilizumab is an interleukin-6 inhibitor, and that was just the subject of 2 randomized controlled clinical trials for scleroderma skin disease. And unfortunately, those studies did not meet their primary endpoint. So meaning it didn't show definitively that it improved scleroderma skin disease in early disease. But it is very effective for inflammatory arthritis. And then there's under the fifth, they kind of say, well, if those things don't work, there are lots of other drugs that are used for rheumatoid arthritis. Try one of those. So there is a little bit of consensus at the beginning, but many options on the other end. So those are the 7 disease states that are described for scleroderma. Is this something that you guys want to ask some questions about or talk about, or how should we proceed?
Let's open it up, and I'm not sure if like I said, how this is. We're working underneath a new software this year versus last year. So if somebody has a question, why don't you raise your hand within your controls that you have, and I'll unmute you, and then basically you could try to ask the question, or write me the question, and I will pose it. So I'll ask everyone who's on board if there's a question. I'll just go down there where raise your hand. Use the raise your hand feature within your toolbar from Zoom, and I will then unmute you. And if not, we will go on to the next one. So we'll wait a moment. I don't see anyone raising their hand asking for a question. So I would say right now, Doctor, why don't we move to the next part?
Sure, we can do that. Thank you. One thing I would comment, I know it's a little overwhelming to look at these tables and that, but those are something you might just print out. And if you had a question, you might take just one of those slides to your doctor. If you had a question about it and say, hey, I heard about this from the Scleroderma Foundation. Can you explain to me a little bit more about why we're using the medicines we are using? It might be a tool to provoke a conversation with your doctor.
Yes, the one thing for sure is that to make sure all of our patients know that you have to, the best advocate is yourself for yourself. So don't be afraid of asking the doctor that they won't be insulted by you. It's not challenging them, but basically you're asking questions to educate yourself. So basically when your family asks you, why are you on this medicine? You can explain that to them and what were the thoughts in the process that the doctor chose that for you. So we'll go to the next.
let's move on then. I guess then we're not going to take a break, and we'll go on to goal setting for self-management.
Okay.
So, yeah. So there have been a number of attempts to have self-management courses for people with different types of rheumatic diseases. The first was the arthritis self-help course, which was put together by Kate Lorig and a guy named Jim Freeze at Stanford. And it was one of those things they really learned a lot about how people cope and manage diseases on their own.
Doctor, we had someone come in with a question, have raised their hand, so let me unmute them. And
oh, yeah.
Let's see.
Doctor, I apologize. Can you hear me?
Yes, we can.
Sure.
Oh, I apologize. It took me a while to figure out how.
No problem, ma'am. Please ask your question for the doctor.
Doctor, with regard to the interstitial lung disease, in the preferred treatments, and you had listed that the third level rituximab is being a consideration. I experienced rituximab and also ran into some serious insurance problems because of the lack of FDA approval for the use of that drug to treat ILD. Can you comment on that or tell me, please, if that has changed?
Yeah, so no, that's an excellent question. And this is the problem of having a rare disease, is that with the Obama health plan, they basically made it illegal for a health insurance company to pay for a drug which is not FDA approved. But being that scleroderma is not really a very common disease, there's not a lot of incentive for the insurance companies, or sorry, for the drug manufacturers to spend millions and millions of dollars to try to get more studies done in rare diseases. So there are, if people have private insurance, then often the doctor can write a letter of appeal and then basically say, look, these are the 6 studies that have been done that have shown in people with scleroderma it can provide benefit. It takes a couple hours for the doctor to do it. There's work to it. But in people with private insurances, it's relatively easier to gain access to that. In terms of the people with Medicare, it's a lot harder. If people have interstitial lung disease, then one thing that's kind of interesting is the insurance companies have to pay for it. If there was like a research study where rituximab was one of the options in it, even if they were just evaluating safety, then the insurance company by law would have to pay for it. So that's a little kind of side run around payment. The other possibility is there are situations where you could admit someone to the hospital and they could receive rituximab in the hospital. And that would, again, basically be an end run around insurers. The challenge might be, though, usually you will give a pair of 2 infusions. So you admit them for shortness of breath, let's just say, they get a rituximab infusion. They should get a second treatment 2 weeks later, because it's a 6-month like course, an infusion now in 2 weeks, and that would last the whole 6 months. So that is another kind of problem with it. I think again, the Medicare issue is really it's a problem. You can make appeals. And once I was trying to get rituximab for somebody, actually, I take it back, mycophenolate for someone, and they wanted me to go before an administrative law judge in Rochester, New York. So Medicare makes it really hard, and there isn't always a solution.
Okay, thank you, Doctor. We have Connie on the line who would like to ask a question. Let me unmute her. Connie, what's your question for the doctor? Connie Graham?
Can you hear me?
Now we can hear you, yes. What's your question?
I was wondering how long the maintenance is done for when you have mycophenolate mofetil as a maintenance. Is that something that's continued for a couple of years or a lifetime, or does it depend on the individual?
Hold on. For some reason, let's see what happened. Did we lose the doctor?
Can you hear me now?
Oh, there we go, doctor. Thank you.
Yeah. I think somehow I got muted. I'm not sure how that happened, but
That's okay.
yeah. So that's an excellent question. Thank you for asking it. So the way doctors typically follow people's interstitial lung disease is by following pulmonary function tests. And the best thing on that is the forced vital capacity. So we follow forced vital capacity over time. And then increasingly, we get regular high-resolution CT scans of the chest. So in some ways, you're looking at the function of the lung, and the other way, you're looking at the structure and how much scarring and scarring-related changes are present. So depending on what's happening, if people's lungs are stable over a period of time, let's say we do these tests a couple times a year, for example, you might decide after a year or 2 years that maybe you want to try to taper off the mycophenolate. And so that would be one, and typically you wouldn't just stop it, you might cut it back by a quarter or a third and observe it for 2 or 3 months and then make changes based upon what you see in terms of the lung itself. Now, the interesting thing about mycophenolate is it was first used for organ transplantation like kidney transplants. So there are people certainly have taken mycophenolate for decades safely.
Okay.
Azathioprine similarly.
So it's basically it's depending upon improvement in the situation, but there is no, you can only take it for a certain amount of years and then you have to get off the drug, correct?
Yeah, that's right. I like to see a year of clinical stability before I try to taper these medicines.
Okay. All righty. Those were our questions. I'll let you get back, and I'm sorry to interrupt you, but back to your goal setting for self-management.
Yeah. So, so everybody is a self-manager. Either we choose to be a poor self-manager, and we use ineffective approaches like denial, or wishful thinking. I wish I didn't have scleroderma. Or withdraw, like allowing depression, drugs, or alcohol to dominate our lives and isolate us from others. Well, these approaches do not work as the problem, scleroderma or whatever is your main health problem, follows its natural path. And that means you have less control in your future, and it leads to missed opportunities and regret. Can you go on to the next slide?
There you are.
One more. Go one more slide. One more. Thanks. Or you could choose to be a good self-manager. And that means you recognize which problems will be temporary and which are persistent that are bothering you, that you use effective approaches like trying to focus your attention and your efforts towards breaking down the problems you're having and trying to think up strategies to deal with them. And that thought process and mental activity makes you feel more in control of your life. And it does help you to make the most out of life's potential and to reach goals. So there are 3 main tasks of self-management. One is take care of your illness. And that means we all have to take responsibility for our future. And that means being informed and being a little bit of a student about your illness and your treatment options. Committing to taking and monitoring medicines that you agree with your physician that you want to take. And being aware of your illness, monitoring it, and reporting the changes to your doctor. Often the doctors don't know if you don't tell them. The other key thing is to maintain your normal activities. We all have to adapt to keep up our home and our work-related activities. You have to find ways to exercise, whatever that means to you. When you say, I exercise, it might be different for you than it is for someone else of a different age or different health problems. But you have to try to do that. And then work to maintain family and social relationships. It's so easy to burn out the ones who care for us the most and who are the closest to us. You want a table that's got 4 legs of support, not just one leg, which is your spouse. I think that it's important people grow in their social responsibility and purpose. And what I mean by that is that we look beyond ourselves, that even though we're coping and dealing with health problems, that we find ways to have an impact on the people around us, maybe in our communities, that we feel are improving. So a great example of this, John is committed to helping the Scleroderma Foundation in terms of these webinars. That could have a big impact for a lot of people. That's great. Somebody else might pray for a friend. Other people might raise money for a cause. Someone else might feel that their social responsibility relates to being an encouragement to a neighborhood kid who can't read very well. But that aspect of looking out beyond ourselves is an important part of maintaining competence and happiness in life. You also need to manage your emotions. And it's of course a natural thing if you have a chronic disease to feel loss and maybe depression, and of course anxiety about the future. And you can make a choice. You can try to ignore those feelings that you have, and it can cause a lot of problems with the relationships of the people around you. Or you could try to recognize that and try to be constructive and proactive in trying to manage those feelings. Can we go on to the next slide? So setting personal goals is knowing and pursuing the things that are most important to you. That's called goal setting. Generally, though, our goals are too big to accomplish all at once. So a good approach is to try to break down goals into smaller steps that you can make progress in over a period of a couple of weeks. And by working through multiple small goals, a term for that is incremental goal setting, can lead to major progress towards your bigger goals over time. So remember that chronic problems also have their own natural variation, and that symptoms may vary from day to day, week to week, month to month, or even season. So even as you start a new habit, you might find that there might be a time of variation. Try not to get discouraged by that. Next slide. So how do we do this? Well, first you got to identify the goal. What do you want to do for your health in the next 1 to 2 weeks? And then you need to create an action plan. Well, what is it? Where am I going to do it? When is it going to happen? How much? When am I going to start? And you want to try to summarize that into one sentence. Then you want to rate from 0 to 10 how sure you are about carrying out your plan. If you say, well, this is my plan, but I only think I'm about 6 out of 10 certain I can do it. Well, maybe you're really asking too much of yourself and you need to adjust your plan. And then you need to self-monitor and make yourself accountable. Tell somebody else, hey, this is my plan for this week. Or write it down in a log, or share with someone else, share with your spouse, this is what I'm going to try to work on this week. And then tell them how you did. Hold yourself accountable.
And let me just add, and if your spouse asks you how you doing on your plan and you're not doing well, don't bite their head off.
Right. Take responsibility for your own disease.
Yeah.
Nobody cares more than you do.
Yeah. They're a caregiver, but you're the one who has to take care of yourself.
So let's go to the next slide, because it kind of breaks this down into 3 phases of working to achieve a personal goal. So we could kind of brainstorm here, and we could make a list of problems that we encounter with scleroderma. If you're listening to this online, you might just pause this right now and take a piece of paper and write down a list of some of the things that you have difficulties with. And then you can start again. And then you might, so let's here's the list that I developed. Can we go on to the next slide? So hand stiffness, finger ulcers, fatigue, worry about the future, reduced ability to tolerate activity. I'm sure you could add another 5, but pick one. Next slide. So then we want to try to brainstorm and say, well, what are some things I might try to improve the problem? That's the action plan. Well, if I've got hand stiffness, I could try doing hand exercises, or I could start a new hobby that uses my hands more, or I could apply heat with a compression glove for a paraffin bath, or I could use over-the-counter creams. I could meet with an occupational therapist, or I could talk with my doctor about maybe medical options for hand stiffness, like anti-inflammatory medicines, like the ones listed below. All of those could work. Next slide, please. So I've decided for hand stiffness, I want to try to do hand exercises. So then we got to say, well, what are the steps I need to start working on my action plan? And I wrote out get a list of exercises to do, learn how to do them correctly, and make an action plan of how I'm going to start doing them. Next slide. So then I thought, well, what resources do I need to actually do this? Well, I could talk with a friend who has experience with scleroderma. I could talk with my rheumatologist. I could talk with a physical therapist or hand therapist that knows me. Or what does everybody else do? Do an internet search. So that was the first thing I did. Next slide. So I typed in hand exercises for scleroderma, and I was actually quite surprised what I found out there. And here we have actually a website and actually a YouTube video related to the Scleroderma Foundation. And there's Janet Poole, a really very well-known occupational therapist in New Mexico, who's had a real life commitment to helping out people with scleroderma. And she has a Scleroderma Foundation 60-minute online presentation about doing hand exercises. I looked at that, and the first 25 minutes were plenty. So that's kind of interesting. Let's go on the next slide.
And let me just add one thing. Very important is that by looking at your Google search, the first three things were coming from the Scleroderma organization. So from that standpoint, always make sure that you're dealing with, I should say, proven sources for your internet source information.
I think that's a really important statement. There are other things that came up. There's another one from Self-Management Scleroderma. Anyway, that was one of Janet Poole's things. So there's some exercises. There's also a handout, and I downloaded it. And that handout is on the right-hand side of the slide. And it kind of explains how to do that. And I actually think that working with an occupational therapist probably would be the best way to go. But, that costs money. You have to have access to someone who's familiar with this. And perhaps starting on your own might be a reasonable way to go. So that's what I chose to do. Let's go to the next slide. So this comes back to what you were just saying about validating the results of an internet search. Whose information can you trust? Well, I think advocacy organizations that are good, like the Scleroderma Foundation is very good. The American College of Rheumatology is great. MayoClinic.com is very respected and a good source. But also, a friend who's coping well with scleroderma might be a very good resource for you too. Or your rheumatologist, or the staff in their office who know you. Again, people who know you, a physical therapist or occupational therapist, your family physician. All those are great sources to validate information. And with the internet, there's a lot available that can help you to get past, to structure self-help activities pretty inexpensively. Let's go to the next slide.
Just on that comment, let me just add for everyone else who hasn't gone through the Michigan chapter of scleroderma is that there are an extensive list of doctors for the various things that scleroderma does affect as rheumatologists, cardiologists, and things like that, and also where they're located. So that you can always go to scleroderma.org Michigan chapter and find information on doctors that we know of, and that I'm not saying we're endorsing, but who have treated our patients in the past.
Well, I think the Michigan Scleroderma Foundation is a really very excellent group. I've worked with a lot of different patient advocacy groups in the past, and I think nobody really does a better job than you guys, and I'll give you credit for that. That's why I'm doing this. So let's go back to creating now an action plan. Well, there are 4 steps. And so what would you like to do for your health the next week or two? Well, you have to find the behavior that's specific, measurable, achievable, relevant, and timed. Next slide. So that's sort of the what, where, when, how much, starting when. We want to summarize that in one sentence. So let's go on to the next slide. Then we're going to rate it 0 to 10. And then we're going to, and like I said, 0 means you're not sure at all you can do it. 10 means you're completely sure you can do it. If it's less than 7, maybe you need to revise it. Then how are you going to self-monitor and hold yourself accountable? If you were in a self-help course and you met once a week for 6 weeks, you could just tell the group that's what I was going to do, and we'd ask you about it next week. Now, maybe things are a little different. I don't think those resources are so much available. But you want to keep track of how well you carry out your plan. Like I said, talking with your spouse or a friend might be helpful. You might set a date to disclose your progress, either in person or on phone or on FaceTime. Look at someone in the face and do it. You also want to evaluate and plan how to build on the success that you had or learn from your failure. How did it go with your plan? What do you want to do next week? So let's go on to the next slide. So the first thing was for our example, is I identified the goal. I want to improve the flexibility and grip of my fingers. Well, what's my action plan? Well, what? Well, I'm going to do flexibility exercises for my hands. Where? At home. When? Twice a day, after breakfast and dinner. For how much? For 5 minutes at a time, 4 days a week. When are you going to start? Monday. So now I'm going to summarize that in one sentence. I will do flexibility exercises for my hands 5 minutes after breakfast and dinner, 4 days a week, beginning Monday. Well, how sure are you that you might be able to carry that plan out? Maybe 4. Sorry, maybe a 6. Well, that's less than 7, so maybe I'm having second thoughts that I reached a little too hard. Maybe I'm going to modify this. Okay, I will do flexibility exercises for my hands 5 minutes after breakfast, 4 days a week, beginning Monday. I feel pretty certain I can do that. I think that's an 8. So I'm going to write this on my calendar. That's how I'm going to monitor it. I'm going to tell my spouse I'm going to do this, and ask him or her at the end of the week to look at me, look at the calendar with me, so I can tell them how I did. Does anyone have any questions about that process?
We'll give it a moment and hopefully people can figure out how to raise their hands.
Okay, let's go on to the next slide as we do that. So this would come to your turn, and to try to, you can follow this exact format. This kind of process, it's also called motivational interviewing, has been used for years and years. It's used for dietary changes, starting an exercise program, many, many behavior changes you would like to make. Any
Hello,
takers?
can you hear me?
Yes.
Oh,
Yeah.
hi. Same as last time, I just figured out how to be able to ask a question. And I don't have a question regarding the self-help or self-manage. The information was very good, but my question is regarding Raynaud's. And I am trying to figure out what exactly is considered to be a Raynaud's attack. I see some gray area.
I'll ask, are you saying what is determined as a Raynaud's incident, or is that your question?
Yes, because I understand that, let's say if I have more than 2 a day, then I should take medication. And I would like to know what is considered one incident or one attack. Let's say if my hands get whitish, is that considered an event? Or if one of my digits, one of my fingers go completely white, is that an event? What if it is something in between?
I think I could try to answer this briefly. I mean, this is a really big topic. We could talk about this for a half an hour, and I don't think it really directly relates to the self-help. But what I would say is that Raynaud's only needs to be treated when it impacts your life. So if you are having blanching of the fingers with cold exposure, and you have sensitivity and stinging and it hurts, that's an attack. And so does everyone who has 2 attacks a day need to have treatment with medicines? Not necessarily. It depends on how much it impacts your life. Some people find that avoiding the cold, or by using scarves and mittens or hand warmers, that those behavioral treatments are sufficient, and they don't really necessarily need to take medicines. It's usually more severe in people with scleroderma, and more often people will take medicines, often from, like in Michigan, from October and maybe finishing in May, and maybe might not take it in the summer.
Okay, good. Thank you, Doctor. We'll get back to you to creating your action plan on basically keeping yourself accountable to yourself. And I guess that's very important, is that, as you mentioned earlier, is that one of the messages that we've been preaching over the last 6 months and a year, and from yourself and other doctors, is that even though scleroderma is not curable, it's treatable. And that's an important distinction in things. And these are things that help you treat the disease, and what you can do to help yourself. And as you stated, it's very important that you stay engaged to, be the best person you can, because you're the only person who can help yourself.
So that concludes my comments. Last slide. I want to thank the Scleroderma Foundation for letting me chat with you tonight, and I want to thank the participants for coming on in the evening, and for sticking with us. And I want to encourage you and wish you good luck in pursuing your goals. So I'm going to go ahead. I'm going to sign off.
Say thank you very much, Doctor, and I appreciate your time and efforts, and what you have given back to not just the community, but tonight, but also over the years of your work on scleroderma and with your patients. And Michael, would you like to add anything?
Last slide, please.
Oh, we got a last slide there to go to.
What side? Downtown Grand Rapids.
Just a couple of points. This was very clear, precise, thorough. I'm just sitting here. We've had so many technical issues in the past. I've just been sitting here with bated breath, keep waiting for the proverbial other shoe to drop, and it hasn't. Thank God. So we made it, John. Anyway, and thank you very much, Doctor. But an important thing to follow up on is you made about communicating with your doctor. As I said, I am a patient advocate. I suffer from this, and I am a member on self-help groups or advocacy groups, 10 or 12 of them on Facebook, and I see where people, are outside of their doctor's appointments after they've met with their doctors, and then they're asking all the questions on social media. You paid good money, or your insurance did, to have an audience with your doctor. That's where you ask the questions. If you got questions about you don't like their treatment, you love their treatment, or just a compliment, but that is your time with your doctor. Whether it's the 20 minutes, 40 minutes, or whatever time is allowed, that's when you communicate with your doctor, not on social media, criticizing where I should ask these questions. Anyway, I wanted to follow up.
Can I make a comment about that?
Sure, sir.
So basically, the Obama health plan forced all doctors to use computers, and they all hate them.
Yeah.
But it's not to say it's all bad either.
Right.
And one of the positive things is it's forced them to all provide a free portal.
Correct.
And so if you are on this webinar, you probably have access to the internet, I'm guessing, and you can ask follow-up questions to your doctor.
Yes.
And so that's not to say you should write a question to the doctor saying, what is the meaning of life?
Correct.
But it's a very efficient way that I will communicate with my patients about topics, or someone will ask me a question and I might write 2 or 3 sentences and send them a link of someplace else to go. Or I have a lady who lives in the Upper Peninsula who sends me her blood pressure readings every week or 2. So little bites of information after the office visit sometimes can bridge them well too, and you should use them.
Yeah, the portal is great. I have a portal with the 2 local health centers that I belong to, one private doctor in his clinic, and then the U of M. So I think I have 4 portals. But as you said, number one, it's a font of information, it's communication. And even if the doctor says your question or your symptoms or whatever, we need to see an office visit. But they every time, whether it's even a billing question, they follow up with me. And that's the great thing. But like I said, I just see these people that are seeking the advice of people on the internet where, they should be talking to their doctor. So that is a great thing to clear up. But, and another thing on the, I had the choice of the chemo infusions, and I chose the path of mycophenolate, which originally I was going to be on for 5 years. My rheumatologist is Dr. Danish Khanna, which I'm sure you know who he is. And I'm very blessed to have him as my doctor. And the question would have been last fall when it was my 5 years. And my wife asked him at my yearly appointment, and he said, because I responded so well to mycophenolate that they found, research shows that if they do wean people off it, like in my case, it tends to come back with a vengeance, and then it doesn't react as well to as far as the scleroderma to the mycophenolate. So he says, I'm probably going to be on some dosage of it the rest of my life. But on that aspect, it has saved my life. And I don't care nobody's going to win that argument against me, because once I got on mycophenolate, my breathing improved, everything. My skin score went from 19 down to I'm 0 right now, pretty much. So it's a saving grace. But as a follow-up too for Doctor, you do have a Saturday, May 4th of this year, a morning seminar with the Scleroderma Foundation in Grand Rapids. My understanding I've covered. So I might myself personally come see you on that one. So, but anyway, I don't know if there's any more questions people have.
I don't see anything for right now. I will say thank you to everyone who's attended this webinar, especially Dr. Martin. Thank you very much. And Michael, thank you for co-hosting this with me. And with that, I'm going to say good night. And thank you all, and go have a good evening and best of health, and make sure that you understand you control the outcomes of part of your life. Keep working at it. As like you said, the second half of this presentation shows you what you can do to help yourself. So thank you.
Thanks, John.
Good night.
Good night.
Good night, folks. Thank you, Doctor.